Assalamu alaikum. Thank you very much for the organizing committee for this kind invitation for my first time in Bahrain. I will be very glad to talk to you about the state-of-the-art management of arterial hypertension. I have no conflict of interest of this lecture, except that I would like to thank very much my previous fellow Khadija Al-Assas. She was the best fellow ever we had since I came, at least when I arrived to Saudi Arabia. So thank you, Khadija, for being that. So I was looking at the guidelines because, as Dr. Told you, I am more focused on imaging guidelines and valvular disease. But then when I looked at the hypertension, since 2020 till now, we have at least 6 guidelines, either from Canada, from United States, from Europe, from Japan, the International Society, who focus more on the low-income countries and try to adjust these guidelines we're having in Europe and United States to the low-income countries. So please feel free to choose, because I looked at most of them, and most of them focus on the main point that I will summarize for you now. And the problem of managing hypertension is actually huge. When I looked at that, it's amazing. You can spend times and hours and hours. But I will focus only in a few issues today. The magnitude of the problems, the definition of the hypertension, which is still under debate, the cardiovascular consequence of hypertension, the management of uncomplicated hypertension, management of hypertension in some specific population that are close to cardiologists, and how to improve the adherence and the outcome of hypertensive patients. I will not discuss the frail patient. Doctor after me will talk about it, the isolated systolic hypertension, the resistant hypertension, the white coat and mask hypertension, secondary hypertension, hypertension in pregnancy, and COVID-19, because all of this needs maybe hours and hours to talk about them. Some facts, I'm sure you know all of them about it. Doctor told you also about the leading cause of global disease burden. It's the most common cardiovascular disorder in the world. 1 billion person is diagnosed with hypertension, and will be 1.5 billion in 2025. 10 million are deceased every year worldwide. 50% of stroke and 45% of ischemic heart disease are attributed to hypertension, and there is continuous relation between hypertension and cardiovascular events. In other words, each increase of 20 millimeter mercury in systolic blood pressure or 10 millimeter in diastolic is associated with twice increase in risk of death from stroke, ischemic heart disease, or other vascular disease. But unfortunately, despite all this information, only 20 to 50% of treated patients achieve the target at home. Look at that. This comes from the worldwide data. Hypertension is a silent killer. It's the first #1 killer in the world, 10 million people. How about Bahrain? Bahrain, it's a little bit going overrun by diabetes, but it's the 3rd cause. But in Saudi Arabia, they are following the rest of the world, being the hypertension being the first killer in that country. So the untreated patient or inadequate blood pressure control are associated with increased risk of total and cardiovascular mortality. And actually, the risk of cardiovascular mortality increased by 75% in uncontrolled hypertensive patients, even if they are treated, but you are not reaching the target. As you can see here, whether you are untreated or uncontrolled, you have the same burden of cardiovascular mortality and morbidity. However, on the other hand, every 5 to 10 millimeter reduction of systolic blood pressure will significantly reduce the major cardiovascular events. This is a study meta-analysis from more than 600,000 patients. Every time you decrease the blood pressure, even by 5 millimeter mercury, you will improve the outcome of this patient by 10%, and 20% the major cardiovascular disease if you decrease by 10 millimeter mercury. How hypertension leads to myocardial dysfunction? I'm talking from the point of view of a cardiologist. There is pathological change of the LV during the long-term exposure to chronic pressure overload, starting by the activation of the renin-angiotensin system, which lead to increase of myocyte size, increase in number and size of the myocyte, alteration of extracellular matrix, increase of myocardial fibrosis. You know, fibrosis is very bad for the heart. Abnormalities of intermyocardial coronary vasculature, including medial hypertrophy and perivascular fibrosis. Mechanism of arrhythmia. Once you have all this fibrosis and all this mechanism, you will have activation of the renin-angiotensin, you will have sympathetic activity activation, chronic inflammation, electrical and structural remodeling of the myocardium, LA stretch, LA dilatation, left ventricular hypertrophy, and genetic factors, of course, occur in some people, and then you will have atrial and ventricular arrhythmia. And when you talk about ventricular arrhythmia, you think of sudden death. And believe or not, there is a close relation between sudden death and hypertension through the left ventricular hypertrophy, disarray of the myocyte, myocardial ischemia, myocardial fibrosis, neuroendocrine effect, electrophysiological instability, and eventually sudden death. So one of the arrhythmia that is really, really dangerous, and it does not kill as suddenly, but it kills in a shorter way, the dangerous lesion between atrial fibrillation and hypertension. And actually, it's a very, very frequent association. And in AFib patients, hypertension is present in 60 up to 80%, probably even more in patients with atrial fibrillation. And even if you have isolated fibrillation and you don't have hypertension, look for it because it will be masked and is often underdiagnosed. And the atrial fibrillation also, there is common mechanism through the hypertension changes, hemodynamic change, parasympathetic activation, and arterial stiffness, RAS activation, etc. Now, why I talk about arrhythmia? Because the increased heart rate, whether by atrial fibrillation or by other mechanism or by sinus rhythm, is another cardiovascular risk factor in hypertension that needs to be treated, and it's independent from blood pressure control. You can see here, for instance, patients with high blood pressure and uncontrolled heart rate have the same outcome if they control the blood pressure, but they don't control the heart rate. In other words, we have to control both to have the best outcome. Now, I put for you, this is my slide, I did not take it from anybody, how the hypertension may lead to major cardiovascular events. You have the hypertension from one side, atrial fibrillation due to LA dilatation. The coronary artery disease is a major contributor and associated with hypertension, which leads eventually to HFpEF, heart failure with preserved ejection fraction, and eventually late stage HFrEF. This will lead to a repeat hospitalization, cardiovascular death, arrhythmia, sudden death, and of course other organ damage such as stroke, kidney disease, and retinopathy. So really remember that, really, this all pathophysiological. I will give you a clinical scenario, and everybody of us have seen this patient. Ahmed is a 55 years old, Saudi male, 83 kilo, a little bit of heart, overweight, height 1.72 meters, smoker, one box since 10 years, total cholesterol is high, LDL is high, HDL is low, HbA1c is borderline 6%, glucose is borderline, normal renal profile. He has no symptoms, he doesn't complain, but he's anxious. His blood pressure is in your office is 142/88, and the clinical examination, no heart failure, EKG is normal sinus rhythm, but he has 79, a little bit high, and LVH by EKG. I don't have his EKG. My first question for the fellow here, Ahmed is asking you, what's my estimate risk of death, la samahallah, from a cardiovascular event within the next 10 years? He's asking you, I'm anxious, I have all this. People told me that I should know my risk. What's my risk of death? Is it 1 to 4% at 10 years? B, or 5 to 9% at 10 years, 10 to 14% at 10 years, 15% at 10 years, or I'm not sure, I forgot how to calculate it. Anybody would like to have, if I give me, the audience can give me 5 seconds? What do you think, A, B, C, D, or E? Just to make it interactive. D? Who said D? Okay. Other suggestion? Courageous of you. Okay. So basically, this patient, one you have to calculate it. And this is the score chart, comes from Europe, and you can calculate it basically using the fact that he's a smoker, he's a man, the age, the glucose, the cholesterol here by millimole or by milligram, I give it to you both, and he's 55 years old, and the systolic blood pressure, I told you the systolic blood pressure was 142/88 at that point, so let's assume this is the right one. The risk of dying is 9%. So basically, could use it in the iPhone. You cannot invent it. You have to calculate it, and unless you are very good on all the things. But actually, you have to keep it under your hand. It's 9%. He has 9% risk of dying after 10 years. And this is a recommendation class 1 to assess the cardiovascular risk of every patient who has cholesterol and more than 40 years, even whether in Europe or in the United States. Now he's asking another question. What's my risk of having a cardiovascular event within 10 years? La samahallah. 5 to 10%, 10 to 40%, 15 to 20%, or more than 20%, or I'm not sure. Who wants to take it? B? Who said B? Bravo. Okay, he's good as you said, doctor. Okay. In fact, you have to take the ACVD risk calculator, and this is also from the iPhone. It's online. You put the gender, you put the age, you put the race, you put the cholesterol, the HDL, you know, American, the like. This is an American. The other one was European. You put the systolic blood pressure you have, you put the diabetes, yes, no, the smoker, and you calculate up, and this is 11.2. So you are right. It's between 10 to 14% the risk of having an event within 10 years. And this is also a recommendation to calculate this risk for this patient. Now, what do you think about his blood pressure? We assume that he has 142/88. He's hypertensive, no further assessment, just start treatment. B, we need to confirm blood pressure by several measurements, preferably out of office, ambulatory or home. We need to confirm blood pressure as noted in B, but calculate also the risk score in order to know his target blood pressure, or I'm not sure. Who wants to take it? I don't see Khadija, my best fellow. Where is my Khadija? Hi, Khadija. Kifi. So what do you think? This patient is hypertensive or we need more? You say B, okay, B, but we start C, okay, bravo, and we just calculated. So, okay, so it's a recommendation for hypertensive patient, let's assuming it's a really important to confirm the diagnosis of hypertension and to assess the cardiovascular risk factor of this patient. It's 1B, the other one 1C when they don't have hypertension. Okay, how to measure? This looks very easy for you, but for the fellow, if you are in the office, you have a sitting position, don't talk too much, don't ask him questions, let him sit down on the chair. When I was a resident, they told us you have to lay down on the supine in the long position. Now he has to sit down, to be quiet, and just take me out this one. I don't know what's happening here. Okay. Can you take it out, please? Okay. Don't talk and feet flat on the floor and legs. However, we can see that the automated is much better than the hand one, and the oximetric electronic one is preferred method in performing the in-office. And they more closely approximate the ambulatory blood pressure than routine office, and it's more predictive of end organ damage. However, remember, the diagnosis of hypertension is more accurate, and this is the all guidelines I told you when based on the out-of-office patient. And Dr. Raja will talk to you about this white effect and this masked hypertension problems. So remember that if you want to confirm, better to do it at home or ambulatory. Okay? No, I cannot go anymore. Can you let me finish my talk, please? It doesn't go anymore. Halas? Stop? Okay. Okay. So now, how about the definition? So you confirm the blood pressure by at home or ambulatory. Look at the American guidelines. I found it when we released this in 2000, we were talking about with Dr. Ali earlier. If you have now 120, 129, you are elevated blood pressure. And I was listening to a talk to Dr. Azar one time in Lebanon, and he said, if I should follow the advice of American guidelines, 90% of the Lebanese population will be hypertensive. So everybody should be under treatment. It's horrible. And Dr. Ali will tell you also about other problems related to this blood pressure. And as soon as you have 130, 139, or 80 to 89, you are considered as stage 1 hypertension. So Ahmed is considered here, according to the guidelines, Ahmed is having already stage 2 hypertension. So it's a bit different from European. They are more conservative. They take in account the presence of other cardiovascular disease, such as diabetes, stroke, or coronary artery disease, or chronic kidney disease. And basically, it's easy to remember. When you are between 18 to 65 years old, consider that 130 or lower is good, not less than 120 millimeter. And if you are elderly, you can tolerate up to 140. But in all cases, the diastolic blood pressure should be less between 80 to 70 millimeter mercury in all age and comorbidity. So it's easier to remember than the American one. And moreover, I found it's much taken account the whole problem of the patient, not only the blood pressure itself. It takes on account the presence of cardiovascular risk factor, the hypertension-mediated organ damage, and the other comorbidity. So if you take in account that this Ahmed has one risk factor, the smoker, and the hypertension, he's at moderate risk, and he's grade 1 hypertension, whereas for American it's already stage 2. So remember that you have to look at the risk of the patient. Based on that, you will know what are the target of the treatment. Now, the international one make it easier than the European one. This is the International Society. Basically, they take out the grade 3 and they take out the very high risk patient. But it's similar, more of them. Remember that hypertension-mediated organ damage could be asymptomatic or symptomatic. Arterial stiffness, pulse pressure more than 60, LVH by EKG, by echo, microalbuminemia, moderate to severe coronary kidney disease, ankle brachial index less than 0.9, advanced retinopathy, all of them could be asymptomatic, but it means that hypertension are making damage to the heart and to the body. And the other ones were established are cerebral, vascular, peripheral vascular disease, coronary artery disease, atherosclerosis, heart failure, including HFpEF or atrial fibrillation. So this one has to remember to look for them, and we'll see later what. So the aim of the antihypertensive therapy is to prevent hypertension-mediated organ damage, to improve the health quality of life, health-related quality of life, prevent cardiovascular event, of course, decrease arrhythmia and sudden death, and improve overall survival. Can we do that? General management, this is from Canada. I found it very nice. The Canadian guidelines in 2022 updated. The first, you have to start by educating patients. I found it when I arrived to Saudi Arabia, most of the patients really don't know what should be eaten and what should not be eaten. I'm not talking about the educated one, but the comes from all over the country. They ask you, so the rice is not good, the capsi is not good for the heart, and they eat like 3 times the capsi a day. So I think the health behavior management is very important to explain for them, and they insist that all this medication, ACE inhibitors, ARB, beta blockers, and they insist about the single pill combination. We'll talk about it later on. So for the effective lifestyle modification, I always tell to the patient, if you reduce your weight, you will reduce your systolic pressure without medication by 5 to 10 millimeter mercury every 10 kilo weight loss. And sometimes you don't even need any more medication. If you eat fruits, vegetables, low dietary fats, you will decrease also your blood pressure. If you decrease your sodium intake, if you run or you walk very intensively or moderate 30 minutes per day, you will decrease also your blood pressure significantly. And we're not talking much about alcohol because people don't drink alcohol in here, but it's also a kind of risk factor. So the initiation starts always by the lifestyle changes. Even this is from the European Society. And you start drug treatment. If your patient has high risk or moderate risk, you can start immediately by taking medication, or he has some asymptomatic organ damage mediated hypertension, organ mediated appearance. Grade 3, grade 2, you have to treat immediately. You don't have to wait 3 months to bring it back. The problem in daily practice, the blood pressure is poorly controlled. And actually, 7 out of 10 hypertensive do not achieve the target blood pressure. I'm not talking even about 135. I'm talking about 140/90, like the international one. They are very more practical, pragmatic. They want to achieve only 140/90. And the uncontrolled is really, really high despite our effort. Why the blood pressure is uncontrolled? Is it because we don't have enough medication? No, it's not the source of problem. Actually, many randomized controlled trials showed that we can achieve in most of the patients with our medication what we need. The physician or treatment inertia, maybe, because failure to upgrade the treatment, we don't have that time to see them every 3 months. Many patients remain on monotherapy or suboptimal dose despite inadequate blood control. Adherence to the treatment, very, very important. More than 50% of the patients do not adhere to what you are giving them. They forget or they throw it away. Insufficient use of combination, yes, this has been shown also through many, many studies. The combination of drugs through different pathways will work much better if you don't give one medication. So one monotherapy is insufficient in most of the patients, even from the beginning. You have to start by dual. And complexity of the current treatment strategy, of course, one has to simplify it. Oops, sorry. Can I finish my talk? Okay. Thank you. 1 minute, please. I need maybe 3 minutes. I already asked the permission from the chairman. Okay. So, okay. So the need for combination therapy, it's very important. This is just to show you that a good combination is much more effective than increasing the dose of one monotherapy. And when you combine at least 2 drugs from different antihypertensive family, it will give you approximately 5 times greater additional fall in blood pressure than doubling the dose of a single drug. So don't start going 5 to 10, etc., and then eventually think of making combination. And this is just to show you that even from most of the study, multiple therapy are required to achieve targeted blood pressure. Now, from the guidelines European, they recommend the initiation of treatment in most single pill combination. This is really also new state of the art. If you give, for instance, thiazidic and amlor or thiazidic and lisinopril, it's much better to put them on one single pill to improve the adherence of the patient. So the beginning, you start by one pill, dual combination from the beginning, ACE inhibitors or ARB, plus diuretics or calcium channel blockers. Step 2, if it doesn't work after 2 to 3 months, be quick to assess the patient. You can give triple combination. And if resistant, and doctor will talk about my colleague, so I will not talk about the resistant, you can add spironolactone. The management in specific population, we are cardiologists, and you see most of the patients, they have heart failure with reduced ejection fraction or preserved. You start by ACE inhibitor because I already indicated for heart failure. Diuretics, of course, and I added for them ARNI because now we can do ARNI instead of ACE inhibitors and ARB, and they are very efficient basically on resistant hypertension. I found it myself, and MRA. Now, the step 2, they told you to add MRA, but I think for the heart failure patient, MRA should be started as soon as possible. The pillar now in the recommendation 2021 is to put on the one side the 4 medication, the 4 miller plus the SGLT2, which don't have effect on the blood pressure. What about the AFib patient? Hypertension and AFib patient, initial therapy, always dual combination. Protection, ACE inhibitors or ARB plus beta blocker to improve the heart rate. Remember what I told you? Or if they don't tolerate beta blockers, the calcium channels that reduce, like diltiazem, that reduce the heart rate. Step 2, you add a triple combination, ISIN and beta blockers and diuretics or dehydropyridine CCB. Sorry. Yeah, I asked them already. So please stop it like this because it's very stressing out for me.
Okay, we'll go for 1 minute more. Yeah.
Yes, please, but I just need to finish my slide. I make 500 kilometers, so please give me 1 minute. Okay, so about coronary artery disease, I will go very fast. Just to initial therapy is ACE inhibitors or ARB and beta blockers. Remember, coronary artery disease, they need beta blockers for the coronary artery disease. And step 2 is triple combination. Now, I cannot go more further because... Okay, so about diabetes, we want to lower target for blood pressure, and of course we need nephroprotection with ACE inhibitors or ARB, and again, that's association by calcium channel or triacetic degradation. Now, so remember, this is the triangle that you need to remember, the initial combination. You can choose whatever you want, ACE inhibitor or ARB, plus diuretics or calcium analgesic, and beta blockers should be included anytime there's an indication for beta blockers. And all the guidelines recommend the same thing, single pill combination and combination therapy, whether you take Canada, America, Europe, or China. Medication, remember that recognize and stop if you are taking medication that increase the blood pressure, stop them. And لا لا يا عم مش معقول هيك طيب. خلينا نخلص. Okay. So just finally, no room anymore for device-based therapy. In 2013, they were talking about the device-based therapy in resistant hypertension. There is no more room for this unless for randomized trial. The other abnormalities, you have to look for dilatation of the ascending aorta, calcific aortic stenosis, or coronary arteries or HFpEF. And for that, you need to do an echo. This is Ahmed echo. You need to look organized for LVH, ejection fraction, diastolic dysfunction, LA dilatation, and PA pressure. The take-home message: measure accurately the blood pressure, identify hypertension-mediated organ. Do not forget to look for secondary hypertension. Push hard for lifestyle modification. Use the risk score to assess the risk of the patient. Identify and discuss the treatment goal. Account for age and gender and special circumstance. Align treatment with the comorbidity and heart failure presence. Appropriate follow-up, detect and reverse non-adherence. And connect patient to clinician via health information. Multiple drugs against several pathways. Replace multiple antihypertensives with single pill combination. Reassess the patient frequently after 2 to 3 months, and consider referral to hypertension specialist if the blood pressure is not still controlled after treatment with antihypertensive. Thank you so much.